The House Health Policy Committee will come to order. Would the clerk please take attendance?
Chair Rogers.
Here.
Representatives Witset. Carter.
Here.
Hadsma.
Here.
Neely. Here. Glanville. Here. Kafia.
Here.
Conlon.
Here.
Farhat.
Here.
Fitzgerald.
Here.
Miller.
Here.
Reingens.
Here.
Vanderwall.
Present.
Filler.
Yes.
Mueller.
Yes. Here.
Van Workum.
Here.
Roth.
Here.
Schmaltz.
Here.
Thompson.
Here.
Madam Chair, you have 18 members present. You do have a quorum.
Members may want to be careful about following representative yes votes. Just kidding. Right. Representative Conlon moves to approve the minutes from our meeting on April 20th. Seeing no objection, minutes are approved. Today, we will be voting on bills to allow individuals to sign up for the organ donor registry while filing their taxes. House Bills 4362, 4363, and 4364. We have substitutes for House Bills 4362 and 4363 for consideration before voting out the package. We will also be referring House Bill 4361 to the House Tax Policy Committee. Finally, we will hear a presentation from Healthcare Association of Michigan, which represents the Michigan nursing homes and rehabilitation facilities. First, we will be taking up HB 4362, 4363, and 4364, and considering substitutes on 4362 and 4363. To speak to these changes, we welcome Representative Braybeck, and you can begin when you are ready. Thank you for joining us.
Thank you, Madam Chair. Good morning, colleagues. Thanks for having me here today. Before you all have two subs for the bills that we got to talk about 2 weeks ago. These are technical changes to these bills. Both Treasury and the State Department remain supportive of this package of bills.
Are there any questions? Thank you so much.
Thank you.
With that, we will move to adopt the substitutes and then vote to report House Bills 4362 through 4364. Representative Miller moves to adopt the H1 sub for HB 4362. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witset. Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingens.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, 0 pass. The substitute H1 is adopted.
Representative Glanville moves to report HB 4362 with recommendation as substitute H1. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witset. Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingens.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, 0 pass. House Bill 4362 is reported with recommendation as substitute H1.
Moving on to HB 4363, Representative Kafia moves to adopt the H1 sub for HB 4363. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witset. Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingens.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, 0 pass. The substitute is adopted.
Representative Fitzgerald moves to report HB 4364 with recommendation. Madam Clerk. Sorry. Representative Conlon moves to report House Bill 4363 with recommendation as substitute H1. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witset. Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kafia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingens.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, 0 pass. House Bill 4363 is reported with recommendation as substitute H1.
Now we have Representative Fitzgerald moving to report HB 4364 with recommendation. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witsett, Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Cuffia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingens,
Yes.
Vanderwall,
Yes.
Filler,
Yes.
Mueller,
Yes.
Van Workum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, 0 pass. House Bill 4364 is reported with recommendation.
Next up on the agenda, we will be referring HB 4361 to tax policy for their consideration. Representative Reingens moves to refer HB 4361 to the House Committee on Tax Policy. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witsett, Carter,
Yes.
Hadsma,
Yes.
Neely,
Yes.
Glanville,
Yes.
Cuffia,
Yes.
Conlon,
Yes.
Farhat,
Yes.
Fitzgerald,
Yes.
Miller,
Yes.
Reingens,
Yes.
Vanderwall,
Yes.
Filler,
Yes.
Mueller,
Yes.
Van Workum,
Yes.
Roth,
Yes.
Schmaltz,
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, 0 pass. House Bill 4361 is referred to the Committee on Tax Policy.
As someone who has worked closely as a physical therapist with organ donor recipients and those on the wait list, I am very grateful today for this committee's work on these bills and the support for this important policy change. More lives will be saved as we make it easier for everyone to sign up and donate an organ. Thanks. And because May is Movement Month, I am going to go at ease for 1 minute and 1 minute only while we get up out of our seats and move. We will go at ease, call the chair. The Committee on Health Policy will come back to order. Thank you for indulging me in your movements. Finally, we will be hearing a presentation from Richie Farron, Executive Vice President of Government Services for the Healthcare Association of Michigan. He will be speaking to us about nursing homes, long-term care facilities, and the challenges and opportunities facing these facilities going forward. Welcome and begin when you are ready.
Thank you. Thank you, Chair Rogers and committee members for the opportunity to testify this morning. I'm Richie Farron, Vice President of Government Services for the Healthcare Association of Michigan. We represent just under 360 nursing facilities across the state and 260 assisted living communities as well. As you know, the long-term care sector has recently endured its most challenging years. The pandemic and subsequent economic climate have threatened the stability of the sector. Nursing facilities and assisted living communities are facing a workforce and financial crisis, and we thank you, our state government partners, for your continued support as we help our members persevere. Our member facilities play a necessary role in providing care to the state's most vulnerable population. Our assisted living membership consists of homes for the aged, adult foster care, and independent living communities. These members interact with Michigan Medicaid through the My Choice Waiver program, but are predominantly private pay. Further along the care continuum, our nursing facility members serve an older, higher acuity population. The average nursing facility resident is a female in her mid-80s. 65% of Michigan's nursing facility residents are Medicaid beneficiaries. These are your traditional long-stay residents. Michigan Medicaid pays for the care of these beneficiaries. A portion is from general fund, a portion is provider tax from the providers, and then the majority is federal matching funds. Another 15 to 20% of residents are Medicare beneficiaries who receive short-term, short-stay rehabilitation, and a small number are private pay residents. Nursing facilities operate under thousands of federal regulations. CMS contracts with LARA to conduct surveys and ensure facilities are in compliance with these regulations. As you can tell, Michigan's nursing facilities are intricately tied to state government through funding and regulation. We are grateful for the support our members have received over the years and the partnership with the legislature and the administration over the last several very challenging years. While we are thankful that the clinical situation in nursing facilities has greatly improved, significant workforce and financial challenges persist. And we again need the partnership of state government to see us through. Financially, providers are operating on very tight budgets because Medicaid reimbursement rates have fallen below the actual cost of care. Since 2019, the interim Medicaid reimbursement rates have only increased 5%, and that's fallen far behind the 15% or more increase in costs and wages that the facilities are experiencing today. We thank our partners at MDHHS and the legislature for allocating funding to nursing facilities in a supplemental passed in March of this year. Governor Whitmer's executive budget, as well as the House and Senate budget bills, all include funding initiatives specifically targeted at addressing the workforce shortages, including the wage increases for nursing facility employees, of which we are very supportive. We are also working closely with MDHHS in a collaborative effort to modernize our Medicaid reimbursement system. We thank the department and the administration for working with providers on all of these important issues. As I know you have heard from many stakeholders, attracting and retaining a strong workforce is tremendously challenging. There is no doubt that the workforce challenges are particularly severe in the healthcare sector. Since the beginning of the pandemic, nursing facilities nationally have lost more than 200,000 caregivers. That's more than 13% of the workforce. In Michigan, we estimate more than 10,000 losses have occurred, and that's about 17% of the Michigan long-term care workforce. While providers have done everything possible to fill open positions and retain workers, such as offering increased wages, strengthening benefits, providing flexible schedules, helps with childcare, transportation, and much more, providers and facilities cannot do it alone. In the face of these historic shortages, facilities brace for an impending staffing ratio mandate from the federal government, due to be released in the coming weeks. This could not come at a worse time. We all want to increase staffing at nursing facilities, but an unfunded mandate when the workers are not there to be hired will only reduce access to care. The fragility of the sector cannot be overstated. Adverse policy impacting the ability to attract and retain strong workforce, inadequate reimbursement that fails to reflect the increasing cost to provide care, or an unnecessarily burdensome regulatory process could all be catastrophic to the profession. There's much to be done to put the sector on better footing to support the staff and the residents for whom they care for and support every day. HCAM has developed policy proposals aimed at attracting and retaining people into the long-term care profession. It is essential that we establish a career ladder for our frontline caregivers and bolster their reputation as heroes. I look forward to working with this committee on these issues this term. While the challenges are steep, HCAM is confident that continued partnership with state government, including this committee, will help nursing facilities end the cycle of crises. The first baby boomers will turn 80 in 2026. The need for long-term care will continue to grow, and we must all work together to ensure our seniors have access to the care they need. Thank you for the opportunity to testify, and I can answer any questions the committee has today.
Representative Carter.
Thank you, Madam Chair, and thank you for your testimony. I am very aware of what you're talking about. I'm the DPOA for my oldest sister, and she was in long-term care. And I couldn't agree with you more that we need to revise or reform the Medicaid process we have currently using. My question to you, I'm the chair of Insurance and Financial Services, and Medicaid falls up under that. So I wanted to know from you, what do you think would be a immediate fix that we can address some of the issues we have with Medicaid?
I really appreciate that question. Thank you. So, as I stated in the testimony, the cost or the Medicaid rate for fiscal year 22 and 23 was set using an inflationary factor from 2019. And I'm sorry if you already know some of this. I just want to provide some context. Yeah. So normally, how rates have been set in Michigan. They'll use the previous most current Medicaid cost report, look at those costs, and then set the rates for the subsequent fiscal year. During COVID, we had conversations with MDHHS to not go that route because there was an influx of federal money, and there was a lot of changes in operations that were going on. Maybe they were part-time, maybe they were long-term. Some of them were, some of them they weren't. So rather than use those cost reports, because we didn't feel they accurately reflected what the cost to provide care would be going forward, we used an inflationary factor. At that time, we were excited and grateful that MDHHS agreed to that. We did not foresee the 10% plus inflation that happened last year. So what happened was a small increase, 2.5% interim increase was about on pace with what the line was increasing year after year. So we thought we would be good. We weren't. So we faced some significant cash flow challenges. We came forward with some ideas, increasing that interim rate from 2.5%. And actually, again, what I referenced in my testimony that we are very grateful for, that you all voted for in March of this year, was increasing that another 2%. So that's due to go into effect here any day now. The MDHHS issued a state plan amendment to CMS, got the approval. So those funds should start flowing here to providers. So we're, 2.5 up to 5%. We still have a bit of a gap, but it's still very helpful. The next thing I really want to, again, I know I've thanked them a number of times already, but again, thank MDHHS. There's what's called an initial settlement process. So the good news is the agreement was to settle those cost reports to reflect those costs. So providers will see that funding and that Medicaid rate. The problem is, and it's really to nobody's fault, it takes time to audit and settle 430 plus cost reports. So under the statute, that could go out to as much as 21 months. Providers could not wait 21 months to see that funding. So what MDHHS agreed to as part of existing Medicaid policy, again, we are very grateful, is a process called initial settlements. So that gets about 80% of what that full gap would be to providers much sooner. And MDHHS, again, to their credit, is working hard to get those out quickly. I think some of that is already starting to flow to providers. Those cost reports were filed. About half of them in the state were filed on April 15th. I suspect the other half will be filed by May 31st. So we'll see here these next several months a significant flow of funding heading towards facilities, which is great, great news. Going forward is where I think some of the challenge continues. MDHHS does not want to see this lag in payment, and neither do we. So even before the pandemic, we had agreed with MDHHS to work together to go to a more, as I stated, more modernized Medicaid reimbursement system. We are meeting twice a week with MDHHS. In fact, I think my office and MDHHS are on the phone on Teams right now talking about this. They were yesterday morning, multiple times a week. So we're working hard in a collaborative way to get a Medicaid process that reflects these increasing costs of care. Wages alone, wages and benefits are going to make up 70 to 75% of the cost of a facility. Those have gone up 20% plus just on us surveying members since 2019. And as, again, I cited, 65% of beneficiaries are Medicaid. So we're not like a private entity that can increase the price of a hamburger or a good to reflect those increases. We need the Medicaid rate to keep up with that. So I think we're very positive, optimistic about the positive direction we're heading with MDHHS. So love to continue those conversations with you as we continue that work.
I just raised my hand to Madam Chair. I would love for you to meet with me, so after the meeting, if you don't mind.
Of course, absolutely.
Representative Roth.
Richie, thank you for your testimony, of course, and not just the thing that you can't get enough labor or in the staff. I want to ask you a little bit about the review audits that come in and inspect your facilities. All over my district, it is brutal. When these audits end or reviews, these people don't want to do it anymore. Are you hearing that? And if that's the case from you guys too, we need to have a discussion with DHHS. I mean, I have some long care facilities. Those care facilities, long term. I'm sorry, it was a mistake. That there's some facilities that's not all their business that are ready to stop doing it. They'll get a review with a 24-hour action plan. They do the plan, and the state doesn't get back to them for a week afterwards. I just want to hear from you if you're hearing that same kind of concerns.
Yeah, Representative, I really appreciate that question. The regulatory environment in Michigan is one of the most robust in the nation. I'll put it that way. So how it works, again, is federal regulation. We operate under federal regulations. CMS contracts with LARA to conduct those surveys. If you look at the scope and severity of the citations, the number of citations, Michigan is an outlier. At the same time, when you look at the CMS has quality measures, the indicators of quality of care, Michigan exceeds the national average. So something's out of whack here. So yes, we did hear coming out of the darkest days of the pandemic where staff was already burned out, when that regulatory environment was that robust, there was a sense from a lot of staff, a lot of folks whose decades careers in the profession felt thankless. And we lost a lot from the profession, from the burnout, a little bit of the regulatory oversight. So it has been a concern, and every once in a while we call it just gets a little bit out of balance. HCAM advanced some legislation back in 2012 that just put some parameters around this on the timelines for the state to get back to the provider. Of course, the provider should have timelines to correct and get back into compliance. And actually, we were successful in passing legislation supported by LARA, actually that does the survey process last term. And actually just last year, 2022, we worked collaboratively with LARA on that to try to improve the process. I would say since that has passed, and part of that has been a quality assurance committee that LARA formed to ensure that the survey process is being conducted correctly by LARA, and providers know what is expected of them so they can help prevent delays as well. And I think there has been some improvement since that time. I think things are improving. They've brought in some new positions, restructured even the department a little bit, created a whole new Bureau of Survey and Certification within LARA to try to help be more timely, ensure professionalism from surveyors, et cetera, to make that process better. Without hindering any of the goals of ensuring that providers are in compliance. So I think we're trending in the right direction there. We always ask we're in constant communication with our members if they do run into trouble. I think we do have a good line of communication with LARA to go to them, and I think we've seen improvements, really, really positive improvements about LARA willingness to address some of those issues.
I appreciate that. You know, nobody wants to grandpa and grandma or any of our relatives abused, but at the same time, we need to be consistent too. So
Absolutely.
appreciate that. Thank you, Madam Chair.
Thank you. Representative Thompson.
Hello, thank you very much for your presentation. I have a lot of experience in this field. I spent 8 years of my nursing career working in long-term care facilities and short-term rehabs. And what some of my colleagues may not realize is a lot of the long-term care facilities have the adjacent subacute short-term rehab, and that is their moneymaker for that facility because a lot of that is more private pay, whether the patient needs physical therapy or long-term antibiotics, so on and so forth.
Right.
So very familiar with the surveys, being a part of those surveys. as an administrative nurse at some of these facilities doing wound care. And my questions and comments, actually, I have two questions. As far as Medicaid reimbursement goes, how much of that has to do with the way that the services are being billed as far as coding, the correct coding, and how that relates to Medicare? And then what are your thoughts on scope of practice within healthcare professionals that work in these facilities, from our CNAs to LPNs, RNs, possible med techs, things in that line where we can look at how are we taking off the burden for these nurses to help with the nursing shortage. I understand that no one wants a mandate of nurse-patient ratios, but as a nurse that worked sometimes with, on a long-term care side, short-term rehab, you may get 12 to 17 patients. Their acuity is higher, but on a long-term side, you could have 30 patients. You have 30 patients that you're passing medication to from the start of your shift to the end of your shift, in between dressing changes, AccuChecks, making sure that they're getting to their physical therapy, making sure that they're feeding. It is a lot, and it's not providing quality patient-centered care. It is causing nursing burnout, and it's not safe for our patients. Patients are falling. Families are very frustrated. So what are your thoughts on looking into the scope of practice and ensuring that we do have a safe nurse-patient ratio? And how much does the coding, when we do as far as when we're writing the script, how does that affect Medicaid?
All very good questions, so I'll take them one at a time. Our Medicaid rate does not currently depend on that MDS coding. It does for Medicare, as you know. As we are looking with the department at a new Medicaid reimbursement system, how that rate could be set, the department made it clear that they want acuity to be part of that Medicaid rate. One of the ways we're looking at doing that is looking at that MDS, looking at that coding, and incorporating some of that Medicare coding into measuring what that acuity is for that patient to help set that Medicaid rate. So that is something that we could look at. We are looking at and could be included in the Medicaid rate once we can transition to a new system. But currently it's fee-for-service. It's based on that off of that Medicaid cost report. I hope that answers that question. Okay. I'll move to the scope of practice question. So as we explore different tools and ways to help with the workforce challenges, as I stated again, creating a career ladder is one way we think we can help attract and retain frontline caregivers into long-term care. It's a very fulfilling calling, and it is a calling. Not anybody can do it. But we want opportunities for growth, et cetera, once you come to the profession. So right now, when we talk about scope of practice, the biggest area that we are looking at is implementing a medication aid registry. If you ask the nurses in long-term care, they would say upwards of 90% to even 100% of their shift could be spent administering medications. In 22 other states, there's a medication aid registry where a CNA gets trained, passes an examination, and can pass regularly scheduled medications. And studies have shown staff satisfaction has increased, and MedPass errors have actually decreased in those states. So I think there's an area to explore that. That's a bill we're hoping to see move this year.
Thank you very much. I'm very, very supportive of you saying that and giving the numbers on that, because as a nurse, I do feel that would take a lot of the burden and help stop med errors as well. So thank you very much for saying that.
Thank you. As to the staffing mandate, again, we all want more staff, and quality staff equals quality care. Absolutely. This is people taking care of people. That's what the whole profession is. When you talk about a mandate, however, our concern once it comes out through CMS, what are the penalties if you're not able to meet a higher staffing ratio mandate? So the state has a staffing ratio already mandate in state statute. And Michigan nursing facilities are staffing well above that and well above the national average. The problem with the mandate, again, is if there's not people there to hire, how do you meet that mandate? And what penalties come if you don't meet that mandate? So when we say we're opposed to the staffing mandate, we are not opposed to increasing staff in nursing facilities. We are opposed to penalizing facilities for the inability to hire people that just aren't there. I think there's multiple ways to grow that labor pool. I think that's the the focus that we should have. A lot of it is going to the high school students, making it part of, and I think we actually talked about this. When I was in high school, there's something called Career Center, but it was really focused around, mechanics, stuff like that, skilled trades. We should be kind of pushing, long-term care, CNA field as well. I think that's one area we could do. There's also, and it's out of all of your hands, but I think the other answer, when you look at the demographics, it's a numbers game. You have the baby boomers who are all going to be needing this care over the next decade plus. And you have the caregiver generation who is all nearing retirement age, and we don't have just the numbers to backfill that. So we are working with, we have a national association, American Healthcare Association. I think immigration has to be an answer. We continue to hear issues, with green cards and the time that it takes. I have members who look towards countries where they can draw CNAs and nurses, and they'll invest in getting those folks here to work in their facilities, and those folks are ready to come here, but it could take 13, 14 months for them to get there. So it's a long process, and I think at the federal level, we need to take a look at prioritizing healthcare workers when it comes to our immigration policies, because otherwise the numbers, they're just not there. I think that's going to be the major way to address that workforce pool.
Representative Conlon.
Yes, thank you, Madam Chair, and thank you for presenting today. I am the caregiver for my 89-year-old mother in my home, and when I'm here, I have a caregiver at home with her. I know how hard she works for the not great wage she gets from her agency. You just talked about what I was going to ask you about the baby boomers and what we're looking toward the future. Someone was in my office talking about, and I'm at the end of the baby boomers, but talking about, I hadn't heard this before, the silver tsunami that's coming our way. So I'm glad you guys are looking at that, because if we're in this crisis now, what are we going to do moving forward? And I believe immigration, some things you just talked about are ways to go. And I don't know if you have statistics that show exactly how big this crisis and how many baby boomers we have in Michigan, but this is not going to be, this has to be addressed.
Yeah, no, I thank you for those comments, and I'll add a couple of things. We haven't looked at those numbers. At the demographics recently. I could go back and I'd be happy to share those numbers post-pandemic, but it's very clearly a shortage is going to continue, because the demand is going to continue to rise, and there's multiple avenues, I think, to address this. And I think rightfully so, looking at alternatives to the nursing facility. We are not opposed to that. We're against robbing Peter to pay Paul, as we call it, but we are all for a robust care, long-term care continuum. You talk about home health, the person that's at your mother's house helping her when you're not there. You look at PACE, the My Choice Waiver Program. We are very supportive of a robust continuum, funding all of those adequately to make sure Michigan seniors get the care they need. I think, though, the workforce challenges are going to be across the board. We have a little bit of economies of scale working in our favor in a long-term care setting. I know we'd like to reduce those ratios, but you're still able, up and down the hallway, get to multiple folks and care for them. When you're talking about home health, you're traveling one person's traveling throughout the community. So those workforce challenges are only going to be exacerbated at those. So I think everything that I talk about and growing that labor pool, I don't want to speak for any of my colleagues for any of the other associations, but I know we've worked together on things such as, Impart Alliance, and there's other work groups that are put together to try to bolster the wages for those direct care workers in all of those settings and attract folks into long-term care.
Representative Kafia.
Thank you, Madam Chair. Thank you for your presentation this morning. So just sort of piggybacking off of a statement that Rep. Conlon just made about the wages, I was curious for those direct care workers in assisted living facilities, long-term care facilities, what is the median wage that folks can make, maybe starting wage, and then with, let's say, 4 or 5 years of experience, and how does that compare to, for example, neighboring states, if you know those answers?
That's a good question. I don't have the numbers for the neighboring states. I'll start with just CNA. So pre-pandemic, like I said, we've gone up pretty close to 20% for these wages for your certified nurse aide. So your certified nurse aide is going to be that's who you think about who's caring for the individuals in a nursing facility. They're under the supervision of an RN. We also have LPNs. You have occupational respiratory therapists as well, but those folks who are doing that hard frontline work, that's your certified nurse aide. Pre-pandemic, you're probably at around $15 an hour. We're probably looking more like $20 an hour right now. And then we have the direct care worker wage increase that has been in place since 2020. That's at $2.35 right now. And then you have referral bonuses. So if they tell their friends, come work here, we have members who are doing like $1,000 referral bonuses, retention bonuses, bonuses for working, some of the less desired shifts. So on top of that wage, there's a lot more that providers are doing to support those workers. Again, I don't know the exact numbers compared to other states. When I talk to our multi-state providers who have facilities in several states, they talk about how Michigan is at the top of that list.
Thank you so much. And just a quick follow-up, if I may, Madam Chair. So wage, thank you. Benefits, paid time off, sick leave, those types of things. How does that play out with those direct care workers?
Providers are offering all of those to direct care workers. And if you look at the market, they have no choice but to do that. I think we want to do that, but the market is also driving it in that direction. So that's part of the retention and recruitment efforts that providers have undertaken, is bolstering those benefits as much as they can. Now, again, they've under some financial constraint here, but I think you could be confident that when that Medicaid rate continues to grow with those costs, that those incentives for those workers will continue to improve as well.
Thank you. Representative Schmaltz.
Yes, thank you again for your presentation. You talked about reaching out to other countries to fulfill the workforce shortage. Henry Ford did reach out to the Philippines, and as you know, 400 nurses have agreed to come here. But as you said, it takes a long time. I think 2 years, and we're just getting the first nurse to come here from there. Do you know of any other organizations that are reaching overseas, and to what countries, and how robust that is? And you talked about the career ladder. Can you explain that a little bit further, and how you're going to try and keep nurses here and move them up in the system?
Yes, both very good questions. So the Philippines is obviously one of the more popular countries to reach out to. That's where several of our members are going through the Philippines. The other that I've recently heard, some other areas would be like Guam, maybe American territories, where the immigration process is a little bit easier because they're already in an American territory. So we have providers looking there as well. But I think we're at a point, and last year the Board of Nursing changed a rule. I think Henry Ford was really pushing this, and we jumped on board with that. There's what's called a CGF&S exam. Came about at a time for internationally trained nurses to pass an exam to be able to practice in the United States. Since that time, the NCLEX has become widely available. So oftentimes, these individuals, internationally trained nurses, will already pass the NCLEX, and Michigan was requiring an additional exam on top of that, unnecessarily. So I had members reaching out, very concerned about that, because they could be competitive with wages, but they were losing folks who wanted to come to Michigan to other states that didn't require that exam. So just last year, the Board of Nursing changed that rule so that exam is no longer required if they took the NCLEX. So there's little things like that we can continue to look at just to remove barriers and continue to attract as workforce to the state. Things such as reciprocity to other states, we'd be very supportive of, such as the Nurse Compact. So there's several countries I think that providers can look at, and it's just about the process of getting them here that I think we need to take a closer look at.
Thank you. I want to go back to reimbursement for just a second, and just kind of, again, I think you understand this. I'm not sure if everyone in the room understands that reimbursement is what I say, a carefully constructed house of cards, right? So you've got, traditional commercial insurance, you've got Medicare, you've got Medicaid, and then you've got auto no fault. Could you touch on how the changes to the auto no fault reimbursement system has affected skilled nursing facilities? And another representative mentioned the rehab piece. Could you talk about that financial component?
Yes. So the auto no fault, so the TBI patients were not a big part of the nursing facility kind of complement of residents before the reform. We did have some of our hospital-based long-term care units were impacted by it, but most of my members, it was not a major issue for them because that was not a major, those weren't the residents, and therefore that wasn't the payer source. The concern that has arisen a little bit is that as some of those other settings that would care for those TBI patients have had to shutter their doors, some of those patients have been pushed towards our member settings, and it's just not a patient that they're used to having in their setting. So it's taken some adjustment. I don't have the numbers of how that's changed since the reform, but I have heard from members that was an issue post-reform.
Thank you. If you do come across any data, we would be very interested in receiving that.
Absolutely.
And then Representative Glanville, and I think we'll probably wrap up.
I have a comment and a suggestion, I think. So talking about that continuum, the opportunities for growth in the industry, I just have a personal story there. My son started working in a nursing home when he was 15 or 16, delivering meals, that sort of thing. When he was 18, old enough, he got his CNA. He went on to become an emergency room tech. He's done a lot of work in the medical field, is now heading off to med school some 5 years later. But I think, that point kind of points out too, like the CNA position isn't necessarily a career in and of itself. So when we talk about that wage and the benefits, I mean, $15 to $20 an hour, I think we all know that is not a sufficient wage to be self-sufficient. I mean, it really was a great job for him, in early college years. But so keeping that in mind, and then of course as people move up in those career opportunities, we lose them at that lower. So it really is that recruitment piece of how do we get folks into that kind of base level. So, and along those lines, as you're talking about immigration, as the chair of higher ed, I've heard some talk about this too. The difficulty, so another piece to the immigration is the difficulty of retaining students who come here for college. So we're training them and then we're sending them home. So just another facet to have in mind, I think, again, and how we can keep some folks, folks who are coming to us already, how do we keep them here?
Right.
And maybe not having to go out and recruit them necessarily, as professionals from one country to another, but looking at that other end, again, of how we can retain workers here in the state.
Great points. We'd be very supportive of looking at ways to keep them here. I mean, part of it, maybe a little less immigration, but trying to keep them just in the profession. Some ideas that we had was, like tuition reimbursement or forgiveness for years served in the sector. But we're always open to continued conversations to try to address those issues. We want wages to keep going up. It just has to, again, it's Medicare or Medicaid is 85% of the payer source, so that needs to match the ability for providers to meet those competitive wages. So again, I'm always willing to look at how we can keep increasing those wages and benefits for employees. And your son's example, it is an example of how somebody left the profession, but it's also an example of how we can bolster the profession. It is part of a career ladder. While you're in nursing school, while you're in undergrad preparing for medical school, we would love to have those folks come work in the settings, even if it is for just a couple of years. I think that's a tremendous help, and the more you get, the better. So again, maybe there's some ideas along those lines, some help with tuition if while you're at school you're working in long-term care. Open to those discussions. Yeah.
Great, thank you.
Thank you.
Thanks for sharing my story. That's what I did. Representative Reingans.
Thanks, Chair. You mentioned it a little bit just now answering Rep. Glanville's question that touched on the career ladder that Rep. Schmaltz asked about. Can you describe the career ladder of this field to the best of your ability? Because in the Behavioral Health Subcommittee, we talked a little bit about a direct care workforce movement to try to professionalize some professions more. And I just was realizing we hadn't heard much about that in the full health policy committee. So it kind of brought three things into my mind together. If you could explain more of that. Thank you.
Yeah, so the idea for the career ladder is for those CNAs, if they're working as a CNA, is let's try to get them, if they're interested and would like to, move along towards their nursing degree. I think built into the medication aid bill that we have been advancing this last several terms, or supporting the last several terms, is that training and education had to be done in an educational setting. So they'd actually, and we worked with A&A Michigan on some of this language, so they'd actually have to go into call it a community college and get credit. They would earn credits towards that training, so they'd be one step closer to maybe obtaining that nursing degree. So there's a bit of a, I don't want to call it a dead end, but there's a bit of, a separation between your CNA and then your nurses. And how do we get those CNAs to stay in the profession rather than going somewhere else and maybe move up along towards some leadership roles within those buildings, being a supervising RN rather than a CNA. Maybe there's some attractiveness there. The Med Aid bill comes with pay increase and extra duties, so it would be a promotion there, coupled with the education. So, and I know like Impart Alliance, I'm sure you've heard from these other groups, are putting together the professionalization of those direct care workers and other settings. And I think that's kind of bringing those other settings more in line with like where the CNA training is now. It's my understanding of it. I could be wrong. Follow up with them. So I think we are very interested in kind of how do we advance that CNA within, I think MedTech's one way. The other way is we've call it borrowed an idea from the state of California that had recently got a grant program that would specifically focus on certified nurse aides in nursing facilities. A PR campaign was one component of it to try to attract people into the profession. I think that'd be a great idea here in Michigan. On top of that, though, is what they call micro-credentialing. So what would come with that is we would ask the state to recognize this along with providers, and you go through some training. Maybe it's, dementia care. 64% of residents in nursing facilities have some form of dementia, so you do some dementia care. Maybe it's here's a timely one, infection control training, kind of going above and beyond their normal training. Once you get certified in that, credentialed in that, comes with a 25-cent pay increase. So it allows these individuals to continue to gain skills, get educated, get more education, maybe move closer to the nursing degree while also getting some promotions and some pay increases. So I think there's multiple ideas in there that out there already. We're not reinventing the wheel here, but we should continue to look at and implement here in Michigan.
Last question, Representative Carter. Close us out, please.
Thank you, Madam Chair. And I want to echo Madam Chair's request for the correlation between auto no fault and long-term care. Thank you for giving us your perspective. I heard you loud and clear, but I'm really, really interested in the Medicaid reform efforts that's going on with MDHHS. So if there's a way I can be included with that,
Absolutely.
it would be absolutely wonderful.
Okay.
Thank you, Madam Chair, for allowing me.
Thank you.
Thank you. Representative Farhat moves to excuse absent members. There being no objection, motion prevails by unanimous consent. There being no further business before the committee will stand adjourned.